Good morning. Hi, I'm Chris Chia, your director and moderator for the InMode educational live stream series. Today is a great pleasure to be with our really good friend and
Thank you.
colleague and key opinion leader, Dr. Erez Dayan, in his lovely office in Reno, which he's already outgrown. Erez, thank you
very
for
much.
doing all this.
Thank you for having us. Thank you guys for coming.
As usual, we have our crack team. We have Lisa Miller, our PAC, who's the clinical producer of the series, along with the Bravemaker Productions crack crew, Justin Ross and Ryan Windus behind the board and cameras. Anyway, we want to say Dr. Dayan is a board-certified plastic surgeon. He is the owner and director of Advanced Plastic Aesthetic Surgery Center here in Reno. He's already going to build a brand new state-of-the-art office soon, and we're in his current space now, which is serving, would be great. I would love to have an office like this, but you've already outgrown it. He's already a superbly trained plastic surgeon between his time at Harvard Medical residency as plastic surgery, as well as the Dallas Plastic Surgery Institute down in Texas for further training, a full year of just cosmetic surgery. He has too many accolades to list, but among them, he's one of our co-editors for a textbook of just on the cutting-edge body contouring and facial contouring technologies, which was released last year by Theme Product Publications. He's also a key opinion leader in too many things we talk about, including InMode, which we'll talk about today. And coreaesthetics.com is a thing I want to talk to you about when you go live. That seems like a really neat thing, which we'll go into. In a nutshell, what was that exactly, Erez?
You know, I think as more and more clinicians get into aesthetics, we realize that aesthetic training is sometimes not organized or not comprehensive. And I think it's to everybody's benefit, from nurses to different kinds of PAs, all different types of clinicians, to have a consistent educational background. So really, core aesthetics is meant to educate so we can perform treatments such as this safely and effectively.
Well, Erez is near and dear and my partner and I's heart, Spiro Theodoro, and not just because he drew the short straw, picked us up at the airport for a talk one day many years ago. But without further ado, we're going to have the didactic portion where Dr. Dayan is going to go into, as well as a live surgical procedure to follow, and we'll have Rosa Pinto, who is a clinical assistant today in the office as well. Without further ado, Erez, please take it away.
Thank you so much. So we're looking forward to treating our patient. She's in her 40s, a real classic treatment gap patient. So we're going to be treating her with AccuTite full face, so under eye, jowls, nasolabial, submental area. And then we're also going to be treating, and we're going to be performing a little bit of liposuction under local anesthesia. So we'll show you how we do that. We're going to do an axillary roll area as well as above the knee fat pad treatment with Morpheus. So we're very excited to show you the utility of this technology and the versatility of it, how we can really use it head to toe. That's one of the best things for us in our practice is, as a young plastic surgeon, demonstrating how we can optimize technology, get patients very excited about results that don't require a lot of downtime or general anesthesia.
And if I may, I think you're obviously an excellent clinical surgeon, but your business acumen is great. And your return on investment using lines of RF technology, in addition to all the things you can offer in an office situation on the local, like you talked about, which we'll get into, is going to be something.
Yeah, I think it's something I learned from you, Chris, when you guys came to lecture us, is how can you give patients what they want? This is really what patients want. And I think it's important to listen to the patients, and what they want and what gives them results is something that they're willing to come back for. So I totally agree. ROI-wise, it makes a lot of sense.
Well, you're too kind for that, but without further ado, we'll keep going.
Awesome. Okay. So today we are going to be doing a combination treatment, and I'm very excited to show you the utility of the AccuTite and Morpheus device together. What we wanted to do is show you sort of how we can use this device from a head-to-toe perspective. So we are treating a patient in her 40s, and we are going to do lower lids, nasolabial folds, jowls, submental area, and in addition to that, we're going to use the AccuTite for those areas. And in addition to that, we're going to treat her axillary rolls as well as the above knee area. So the nice thing about the AccuTite is that it's a small access point. We're going to use an 18-gauge needle to give us access to these areas. This is all going to be done under local anesthesia. And we're also going to use Morpheus or fractional radiofrequency on top of the bipolar device. So I want to first of all thank everyone for being here. Dr. Chris Chia from New York, Lisa Metler, Justin and Ryan from our production team for making this all possible. And here are my disclosures. I wanted to give credit to Dr. Chia and Dr. Theodoro. When I was in my training, they came and gave us a wonderful lecture about radiofrequency and liposuction under local anesthesia, and that really gauged my interest in these treatments. So here you can see Dr. Spiro Theodoro in the middle, and then Dr. Chia on the left of the screen here. And we have a book that we put together called Emerging Technologies in Face and Body Contouring, which really pulls from authorship internationally, experts on energy-based technologies and procedures under local anesthesia. So I think the trend is very clear. You know, patients want minimally invasive procedures, minimal downtime, and preferably to avoid general anesthesia. The market, for patients, it's very important that their physicians use the latest technology, and I think InMode has really positioned themselves very strongly in this space. You know, as Dr. Theodoro says, it's like when you go to the Apple store, you're not asking for the Nokia flip phone, you want the latest iPhone. So as a young plastic surgeon, this is a big component of our practice, minimally invasive technology, radiofrequency technology, and we use it every day here. So patient selection, I think, is a very important component when treating patients with radiofrequency. What we're really looking at is what we call the treatment gap group. And the treatment gap group is basically patients in their 30s, 40s, 50s, where, for example, liposuction alone will not give them enough skin contraction, but they're not really, quote-unquote, severe enough for an excisional procedure like a facelift or an abdominoplasty. So this is an article written by doctors Theodoro, Del Vecchio, and Chia, really discussing who the treatment gap group is. And it was in the Aesthetic Surgery Journal, so I recommend it, from 2018. You know, the market is full of devices that are meant to treat this group because this group cares about how they look. They're willing to spend money on it. So we're all familiar with cryolipolysis, with ultrasound devices. The problem is most of those devices really focus on fat reduction and not on skin tightening. But really, skin tightening is sort of the holy grail of aesthetics. So how do we bridge the treatment gap? There's a number of energy-based devices, and when we look at it, radiofrequency is actually a very familiar technology. It's existed for almost 100 years in medicine. It's used in every aspect from orthopedics to cardiology to oncology, and really what we're trying to do is very simple. We're passing an electrical current. You can see here on the screen you have your skin layer, then there's a fat layer, and then there's a fascia and muscle layer. And we have fibroseptal networks that are traveling between the skin and the underlying fascia. And our goal is to pass an electrical current through the tissue. And according to Ohm's law, certain tissue types have more resistance. So collagen and fat have more resistance and preferentially generate more heat. And because of that, we're able to induce neocollagenesis and tightening of these fibroseptal networks. So it's almost like a parachute with the strings. These fibroseptal networks are the strings, and we want to heat those in order to bring the skin envelope in tighter for an aesthetic improvement. So there's different ways you can deliver radiofrequency. All the devices we're going to show you today are bipolar, and that's unique to InMode, and I think that the reason why that's been so successful is twofold. Number one, we're able to preferentially heat between the positive and negative electrode. This is in comparison to monopolar devices where the energy is traveling through the path of least resistance to a grounding pad. With a bipolar device, we're able to volumetrically heat very intentionally between the positive and negative electrode and get to a very accurate temperature. The second reason these technologies are very successful is actually have nothing to do with the heat. It has to do with temperature control. So we're able to very specifically heat the tissue to a specific temperature and not exceed that temperature so that we're able to induce neocollagenesis and elastin reorganization. So this is a cross-section showing you how this device looks from a heat standpoint. So you can see the energy is coming from the internal electrode and moving towards the external electrode. So really the action of this device is happening internally. This is an example of an abdominoplasty after liposuction, and you can see this honeycombing of the fibroseptal networks. This is really where we're trying to treat. We're trying to tighten the fibroseptal networks deeply to cause a skin contraction. So what's the mechanism? So one important thing to tell patients is this is not an immediate result. you're not going to feel different immediately after. The goal is to induce an inflammatory and proliferative cascade through the vascular endothelial growth factor pathway, and that's what's going to trigger new collagen formation, elastin reorganization, and as well as angiogenesis and lymphangiogenesis. So this is we show this to patients. This is an example of a before and after, and you can see the area between these dots contracting. So there is an immediate contraction effect, but really the long-term effect takes about 6 weeks to begin initiating. So we use radiofrequency all over the body. One of the nice things about radiofrequency is you can use it from head to toe, and you can also use it in all Fitzpatrick types. As opposed to lasers, for example, radiofrequency is not chromophore specific. So this is essentially a non-specific heating technology which you can use on Asians, African Americans, as well as any other Fitzpatrick type. So this is the array of devices that we use. From the right to the left, you can see the BodyTite device, which is the larger of the hand pieces, and we use this, of course, for areas such as the abdomen, the back, the arms. Then to the left of that, you can see the FaceTite device, which we primarily use for the lower face and neck tightening. And the two devices we're going to use today include the AccuTite device. The nice thing about the AccuTite is it's very versatile. You can access through an 18-gauge needle poke and treat areas that you're unable to treat otherwise with the larger devices. And then the Morpheus device, which is unique. It's a bipolar fractional radiofrequency device where the heat moves from the tips of the needles to the faceplate of the device. And that's unique because many other radiofrequency microneedling devices have the heat moving between the tips of the needles. So the heat energy never actually traverses the skin envelope, and that's unique to InMode, and it's a great technology that we use both in isolation and also in combination with these other devices. So here you can see a very important slide about how the heat is moving and how the device is adjusting its radiofrequency energy. So you'll see as we set the device, we're going to have preset temperatures. And the machine is smart enough to know once we not only reach those temperatures, but it knows to maintain those temperatures. So once we reach our target temperatures, the machine has a thermostat where it's basically going to ensure that we maintain our temperatures without exceeding them. So here's how we perform face and neck radiofrequency treatments. First of all, we can use either the FaceTite or the AccuTite in combination with the Morpheus. And we tell patients, you know, as we age, our face moves from an upside down triangle where we have high cheekbones and a tapered jawline. And as we age, we become more right side up, where the lower third of the face becomes more boxy and we develop jowls and submental laxity. So when we perform radiofrequency on the face, patient selection is critical. We're really looking at the treatment gap group. So these are patients typically in their 30s, 40s, 50s with moderate or mild laxity. Very important to identify active platysmal bands ahead of time, and those can be treated separately with Botox, for example. And when we treat patients, there's a number of ways that we perform anesthesia. So commonly, particularly with AccuTite, this can be done under straight local anesthesia quite comfortably. Some patients, we use some Pronox just to make the treatment a little easier for them. And in some cases, we'll give them some oral Valium, for example, just to calm the nerves. So this is a great example of a very classic treatment gap patient. As you can see, she has some slight jowling and slight submental laxity. Commonly, we combine this with liposuction in cases like this. And here, we're going to review our markings in more detail, but first thing we do is we mark the angle of the mandible, the borders of the mandible, rather, so we can identify our treatment area, and then we mark out the jowl above and below that line. And we label that zone 1 above the border and zone 2 below. The next thing we do is we identify our danger zone. So we bring down the marionette line and we create about a 2 centimeter X. And this is where the marginal mandibular nerve is going to become superficial to innervate the DAO. And this is an area we avoid heating. Next, we're going to identify our submental treatment area and mark that out. And those are really the key marks to avoid a marginal mandibular neuropraxia and identify the target areas, which are the jowls and the submental area. So these are our typical treatment parameters. Typically, we treat most patients at 38 degrees Celsius externally and 68 degrees Celsius internally. And of course, this is adjustable depending on the quality of their skin and other factors, including the amount of subcutaneous tissue they may have. This demonstrates, this slide is demonstrating to you where the marginal mandibular nerve is becoming superficial. So you can see here on the bottom left, you want to avoid that area where it's innervating the DAO, and I'll show you that in real time how we adjust and how we treat the patient to avoid a marginal mandibular neuropraxia. This is a hyperlapse video showing a local anesthesia face-tight procedure. You can see it's done in office. We heat row by row, really tightening the submental neck areas as well as the jowl areas. And this is a FLIR camera. Now, a FLIR camera is not necessary for the treatment at all, but we actually find it very useful for social media, where we can show patients that we're using advanced technology through this near-infrared heat sensing camera and demonstrate the treatment and the heat signature and how it's working without showing things that are too graphic. So I highly recommend getting this camera. It's about a $200 to $300 camera, and it can be bought on Amazon even.
So I had FaceTime done several weeks ago. My results.
This is an example of a patient that we did FaceTite with liposuction on. This is a 2-week result. And you can imagine that if this patient had just liposuction, she would probably have a lot of loose skin. So this is a great example of the utility of radiofrequency in combination. Here's an example of AccuTite and how we can use the AccuTite to target very localized areas, as we're going to show you today. So we'll show you that in a little bit. And this is demonstrating to us here the different sizes. So the size is really helpful for different areas, and it gives us a lot of versatility in our treatment. So the BodyTite, first of all, it's important to notice that these internal cannulas are quite small, which is great because you can really treat patients with minimal access. And today we're going to be using the AccuTite, which is about 6 centimeters long and only 0.9 millimeters in diameter. So it really makes patients feel very at ease. There's not incisions. It's almost, in terms of invasiveness, it's almost like a filler cannula level of invasiveness. But frankly, I feel much safer using it because we can avoid a lot of the issues that we have with fillers. So here you can see just in the palm of your hand the size of this device. And as I mentioned, it can fit through a needle poke. It's very comfortable for patients and very minimal access, so you don't have to worry about too much about incisions. Here's a cross-section illustration of how the radiofrequency is working. So really the energy is coming from the internal cannula and moving towards the external electrode. So most of the heat is really focused internally here. We're not so focused on surface heating. And through this heating, we are triggering a cascade of wound healing. Now the Morpheus device, here you can see a video of it, and we're going to show you in real time. The beauty of the Morpheus device, it's an adjustable depth device, so we can treat at multiple depths and as well as different energies. And we'll show you the different modes, but there's a cycled mode where the needles are coming in and out of the device, and then there's a fixed mode where the needles stay out and the energy is pulsing. My preference is to use the cycled mode because I think the injury of the needles is beneficial to the result. But we're going to show you that in real time, and this in combination with the AccuTite is called the Embrace procedure. And we actually published with Dr. Chia, Dr. Theodoro, as well as Dr. Ravati in Italy, the largest series to date on the Embrace procedure, and that was in the Journal of Plastic and Reconstructive Surgery. So here you can see an illustration of the Morpheus device. As I mentioned, these are coated tips, so the energy is moving from the tip of the needle to the faceplate of the device in a bipolar fashion. And we'll show you some of the nuances of this handpiece, but it's a very powerful fractional radiofrequency device. One thing many people ask is, how does this heat affect the skin? How does it affect the subdermal vasculature, the lymphatics? And we actually published an article about this, and I think it's important to discuss it because not only does it not hurt those structures, it actually improves those structures. And we showed that using a very sensitive camera called the indocyanine green camera made by Stryker. It's called the SPY machine. So here you can see in this video, perfusion, if you go back to the previous slide here, the perfusion is actually maintained throughout the treatment. And this is what we see clinically. So a very important question is how radiofrequency affects perfusion at these temperatures. And so we performed a study using the AccuTite and also using one of the most sensitive perfusion assessment tools available, and that's the SPY camera by Stryker. And this is used to really measure perfusion as sensitively as possible. So we inject an indocyanine green dye intravascularly, and using this near-infrared camera, we can see the areas that are perfused. And basically, we can demonstrate that even with epinephrine in the local anesthesia and the bipolar radiofrequency, we maintain perfusion in all treatment areas. The next thing we can do with this camera is demonstrate lymphatic flow. So the indocyanine green dye is injected in the dermal space, and the subdermal lymphatics can pick up this dye and show us the lymphatic channels. So here you can see we injected submentally and postauricularly, and then we performed a Morpheus treatment. And what we saw is that the needles of the Morpheus travel in the subdermal space, they pick up the dye, and then they migrated the dye. And most importantly, you see that the local lymphatic channels are pumping the dye out, which shows that the delicate lymphatic channels are still functioning, still pumping. And there's good evidence to show, basic science evidence, that when VEGF is upregulated, vascular endothelial growth factor, it actually causes lymphangiogenesis. So there's good evidence to show that we're improving lymphatic flow and the number of channels with radiofrequency heat. So this article was published in the Journal of Plastic and Reconstructive Surgery, demonstrating improved lymphatics and improved perfusion with radiofrequency. And actually there's some evidence to show that with malar edema after facelifts, or with edema in the periocular area after filler, many clinicians are using the Morpheus and AccuTite to improve swelling and presumably improve lymphatic flow. So we're very excited to show you this patient's treatment and to show you how best to use the AccuTite and Morpheus together.
Great, we're back live again, and Erez, fantastic didactic presentation.
Thank you so much.
We'll get more into the weeds with that. I want to ask you about that lymphatic study in a moment. But we must like to thank Dr. Dayan's wonderful patient here today for her cooperation. And without getting too much into detail, we're going to go into the markings, your technique of doing the local anesthetic injection, and we'll take it from there, okay?
Great, so thank you so much, Chris. Thank you for coming all this way and for all your guidance, teaching me a lot of these techniques over the years. So we have our lovely patient here. She's 39 years old, really a great candidate for full face AccuTite, and that's really what I want to show you, is the versatility of the AccuTite device. Now, what I'm going to do is kind of mark everything out, kind of top to bottom. The areas we want to treat in her case are going to be the lower lid, the nasolabial fold, the jowl, and the submental area. We're going to do this all under local anesthesia. We have a very lean system in terms of how we do the local, how we gain the access, so we're really using kind of minimal materials, not because having more materials are bad, it's just easier. So I'll show you kind of the system that we have. It really streamlines things. So without further ado, we'll start the markings. Now we're not going to do brow in her case, but I'm going to show you how we would mark the brow, just so you know. So normally when we're doing brow, we kind of feel for the foramen here, for the neurovascular bundle, which I can feel, and we would mark that out. So we have kind of the supraorbital, supratrochlear bundle here. Of course, we have our frontal branch kind of coming in this direction, right at Pitanguy's point. And then when we do brow AccuTite, we're kind of looking at where the lateral limbus, the colored part of the eye is. That's where we want the brow to peak. And normally we would mark out an area that's about the width of the AccuTite handpiece, just to raise that area. So we would make a little wheel of local here to mess this area just with a few cc's and perform AccuTite to raise this area of the brow. Now, what we're going to do is lower lid. Now, I really like lower lid, and the AccuTite is really ideally positioned to treat this patient's lower lid. So I'm going to have you close your eye. And when you press on the globe, you can kind of see the intraorbital fat herniating. So what we want to do is identify the orbital rim. And what we want to do is identify the tarsal plate. And I'm going to show you what we're going to do is actually treat the SOOF, the suborbicularis oculi fat pad. We're going to inject a little bit of local here and just fill that area up and treat with the AccuTite. Next, we're going to mark her nasolabial fold. And what we want to do is actually treat right above the nasolabial fold so that we're effacing it, and we're going to inject some local here to treat that area. When we're doing lower face and neck, so these markings are going to be applicable not just to AccuTite but also to FaceTite. We like to mark the border of the mandible. And importantly, we like to bring the marionette line down. And this is an area that we want to avoid treatment. This is where the marginal mandibular nerve is going to come to innervate the DAO.
That's lovely. Could you just turn the patient's face to her left slightly? Thank you so much.
Perfect.
Yes.
Okay, great. So you can see here the border of the mandible. the marionette line, and this is where the DAO is, and this is where the marginal mandibular nerve is going to become superficial. It actually trifurcates to innervate here. So if you have a strong heat signature in this area, you can get a neuropraxia. Luckily, I've never seen that become a permanent problem, but it can take a few weeks to resolve. If that happens, you can Botox the other side to even things out. Now, typically when we're using the face-tight handpiece, we'll create an access point about 2 finger breadths inferior to the ear lobule, and then treat the whole lower face and neck laterally from this area. With the AccuTite, I personally like to make the access point right at the pre-jowl here and then treat in this direction. Because really what we're focusing on here is kind of this jowl area right here. And we normally list that as 1 and 2 so that we can really be very systematic about that.
Sorry to interrupt you, Erez, but
yeah.
you mentioned you can use like a 20 gauge or 18 gauge puncture, which is great because there's literally no permanent marks.
Exactly. So that's why with the AccuTite I like to treat kind of from the pre-jowl out, because the access point is so small we don't worry about scarring or incisions. So again, so we've marked out the brow, the lower lid, the nasolabial, the jowl, and then lastly we're going to show you the submental area. So I like to just mark the midline here. And then she doesn't have very much adiposity, but we're going to do a little handheld lipo, which I think is a nice adjunct. The more adipose tissue the patient has, frankly, the better the result, because you get the benefit of getting rid of some of that volume, and on top of that you get some skin contraction. I find that the hardest patients are the ones that are primarily loose skin. So I think from a preoperative patient assessment standpoint, you want to ascertain that the patient has good, relatively satisfactory skin elasticity. It'll make sure that they have great results. A little adiposity like this is beneficial because when you do the liposuction, you're going to get a little more contour. So this is a great example of full face AccuTite. Now, what I'll say is, we've done studies on fillers, and I know fillers are very popular. It's kind of the gateway drug in aesthetics. But I think when patients begin to have soft tissue laxity, the solution is really soft tissue contraction, not volume. So my analogy is similar to like a patient that has ptotic breasts. The solution shouldn't be to put large implants in. The solution should be to contract or lessen the skin laxity. So with facial aesthetics, I think it's very similar. More and more we're seeing patients with overfilled faces. And I think how we have to think about skin laxity in the face is really dealing with the problem, not volumizing. Because then those, as Dr. Baker talks about at meetings, they become very doughy looking or howdy-doody look, as he calls it. So I think it's important that when patients begin to show signs of facial aging, we'd figure out when fillers are appropriate, but really I think radiofrequency has a very big role in those patients.
If you could take this opportunity, Erez,
Yep.
the beautiful mark is if you wanted to, obviously you have to do it on the left side. We can, while you're doing that, talk about other things you add during the, when you can add other procedures in the office setting. You just talked about lipo, which is a wonderful thing. They really maximize the results, devolumizing certain areas.
Right.
We talked off camera about fat grafting. And what else do you like to add?
Yeah, so thanks for bringing that up, Chris. So I think, in patients like this, we have a whole armamentarium of treatments that we can do. And if each treatment gives us a 20-30% improvement, together we can really get pretty impressive results. So radiofrequency is kind of our mainstay, and that's AccuTite, face-tight, body-tight, with or without Morpheus. When we're already doing lipo of certain areas, we can take that fat, pass it through a filter. We use the Microns filter and just a tulip cannula set, and we can fat transfer to areas like the tear trough. So facial fat transfer is a great technique, and I think it's far superior to fillers in my opinion. Plus, you don't have the cost of buying filler materials. So taking that fat and repurposing it, I think, is a huge advantage. Many clinicians who are very facile with threads like to potentially use the addition of threads. I know many people use the MyElevate suspension for the platysmal bands, but in our practice, it's mainly fat transfer. A little poke here. Fat transfer, radiofrequency are really two of our mainstays. So what I'm doing here is I'm just injecting our access points with just 1% lidocaine with epinephrine. She's awake and comfortable for this.
You pre-medicate her, on your slide you mentioned acute PO meds, correct?
We do it both ways, honestly. In this case, we gave her just 8 milligrams of Valium, diazepam. It's not totally necessary. It doesn't really It's not that strong, so she's very comfortable and awake. Well, are you very comfortable?
There's a little poke.
A little poke, yeah.
Great patient nonetheless.
Yes.
Well, while you continue to do that, we want to remind the audience, and we thank those of us who are giving us information through the text feature of the interface. And there's a Dr. Chang who mentioned, would you speak to the concern about fat loss with FaceTite or even Morpheus alone? Because we just mentioned about fat grafting. Or certainly in the face, we want to maintain volume or even augment it. But we also use, I know you and others like Dr. Unger and Nash will do it for the breast, and certainly you don't want to lose volume there. So the question is, patients are finding this online and expressing concern. Also, is it safe in bearded areas? What do you think about that?
Great question. So, it's a very interesting question. In terms of radiofrequency's effect on fat, we've done cadaver studies and also just in our clinical experience, I'm going to have you look all the way this way. We haven't really appreciated, let me see the marking pen, a significant amount of fat loss. Now, one thing that can happen, if patients have a lot of filler, there have been studies to show that at these temperatures, you can melt some of the filler material depending on where the filler is injected and kind of your depths. What we found is in the proper patient population, you're going to get more skin contraction than any kind of effect on the fat. So we haven't really found that to be the case. But it's a good question. I know some people bring it up. Sometimes I think that may be filler more than fat. But as I said, I think that fat transfer is a nice adjunct, but we have not found that patients have looked older using radiofrequency because of facial volume loss at all.
Great, thank you. Also, do you do regional nerve blocks as well, or are you just doing a tumescent type technique?
We're just going to do tumescent here, but you can imagine once we do the tumescent, we're going to knock out the infraorbital neurovascular bundle, the submental. So a lot of this is her face is going to be pretty numb. There's a great paper, I think it's by Barry Zeid. It's an older paper called Bait and Tackle the Face, which is a nice technique. So if you wanted to do nerve blocks very precisely, I think that would be a nice article to take a look at.
Excellent. I know that article because he was an NYU professor. Lisa, thank you for your questions. Lisa is actually going to tackle another one for you.
Great.
So in this case, why did you choose AccuTite over FaceTite?
Great question. So for AccuTite gives us the ability to access areas that FaceTite can't. FaceTite is just a little large to use for under eye, nasolabial. You could do the jowl, lower face, neck, and jowl, of course, with FaceTite. But I think AccuTite is really key to get to those small areas. So this is how I do the tumescent. So we injected a little local here, 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 and here. That's just our access point. Now I have an 18 gauge needle. Like I like to do with the 18 gauge because it avoids the need for a cannula in these cases. So I'm just going to go ahead, just close your eye here. I'm going to make sure I'm under the orbital rim. I'm just going in through my access point, and I'm right on the periosteum. And the nice thing about these treatments is it doesn't take much to just get in right above the periosteum and just tumescent these areas.
What is your formulation for the tumescent?
So when we're doing small areas like this, we can use more local than, for example, if we're doing a larger body area. But normally it's about 40 to 50 cc's of 1% lidocaine with epi in a 1 liter bag. But like I said, here we're not using big volume, so we're not really so concerned about lidocaine toxicity. So we're just slowly going to infiltrate these areas.
A nice dense analgesia.
Yeah. You doing okay there, Robin? Good. So it doesn't take much volume. Now you have to tell the patients they're going to look a little funky from the local, because we do want to infiltrate enough local. I think having a good tumescent is important for a number of reasons. Number one, it makes the radiofrequency conductivity better. It also acts as a heat sink. So there's a number of advantages. So I personally like to tumescent a little more than most, I think. Have you put your chin all the way up?
Yeah, fluid is your friend.
Yeah, fluid is helpful, I think. I think the heat sink property of it in particular. So where we are right now is right above the platysma. It's a natural plane, so it just opens up. It doesn't take much pressure. You can see that.
I have another question for you.
Sure.
Do you use neck fat for facial grafting?
Definitely. I think any fat is good. You can take it from the submental area is great. Some people, when they do like buccal fat pad removal, that's another adjunctive procedure, and I know a lot of people like to use that fat for transfer. Ben Tilley in Beverly Hills, that's his kind of thing. And that makes sense to me as well. we have a nice little filter that'll just make the fat very consistent.
Yeah, that was
So
my next question. How do you prepare it, or how does Rosa prepare
yeah,
it?
we can show you. We have a little filter from a company called Microns. It's made in Germany. And there's just a different little mesh in there that we can mince the fat. I'll kind of show it to you. We have it open actually. It's a very simple technique. So we have this little filter. If I open it up for you, so you just put a syringe on either side and you just pass the fat right through this filter. Very simple device. You know, Tulip makes it as well. So you can easily just. We're going to do a little handheld lipo. You're going to see that we're going to take the fat. We just pass it through the filter. And it's very straightforward. So I'm going to have you look all the way towards me here, Rob. So right here, honestly, I think the hardest part about this is finding where your access point was, because they're so minimal. And we're just going to go ahead and infiltrate this area. You doing okay?
Mm-hmm.
So the audience can appreciate these are office procedures, obviously. You happen to be doing your operating room, but we can easily do it depending on your individual state regulations, what you can and cannot do in a procedure room, which we all have in our offices. So for those of us who aren't utilizing the office-based facility certification necessarily, consult your state regulatory issues, but it should be something very straightforward in most states of the union to do this in your procedure room.
Yeah, this is a routine that we would do this in an exam room. You know, it doesn't really require a whole OR type setup. I mean, to me, this is on the invasiveness of a filler type material.
Exactly.
Okay, so that's pretty much it. You know, as far as the local goes, very straightforward. So we just injected 1% with epi at the access points, then we used tumescent to fill those areas. Let me take a little tumescent on a 10 cc syringe with the same needle there. So how do you feel? You feel okay?
Yeah.
Okay, so the patients, you know, who are obviously not used to being tumescent, they're going to have some, you know, weird feeling just in terms of the volume of tumescent. Mm-hmm. It doesn't feel like totally comfortable. It's definitely a different feeling. Sorry. Okay, so we're just going to put a little more on the lower lid here. There we go. So you see, we just really open that up there.
What are your thoughts about using Morpheus8 in conjunction with the standard bipolar phase-tight AccuTite?
That's a great question. So I think Morpheus is definitely beneficial. And the reason for that is because when we do the AccuTite, which we're going to show you in a moment, we're really heating the fibroseptal networks. The Morpheus, so we're heating from the bottom up. It's really about internal heating. And I think, you know, one of the benefits people ask, you know, what's the difference between this and Thermi or some of the other monopolar J-plasma, which, by the way, we have a paper about comparing these technologies, because all those technologies don't measure internal temperatures. They're measuring primarily surface temperature. But what we're interested in is internal heating. So here I'm putting some water-soluble gel on. This is very important for the conductivity. You want to make sure it's water-soluble, just ultrasound gel. We just get these little packets from our supplier, very straightforward. And we put an ample amount on. But here we're really measuring our internal and external temperatures, but we really want to hit internal temperatures to heat the fibroseptal networks, and then the Morpheus is going from outside in. So we're really focusing on the subdermal heating. So they're very complementary. And I will say the Morpheus is an extremely popular treatment on its own for patients to come in. Sure. Okay, so we're going to go ahead and start on her right. So here's our AccuTite handpiece. And I'm going to have you turn your head all the way this way. Perfect. So here's our AccuTite handpiece. As you can see, you know, compared to my hand, it's about 6 centimeters long. The energy is moving from the internal cannula to the external electrode. And so you have to think that all the action is happening internally. Nothing is really coming from the external electrode. This is just a return electrode. So what we want to do is treat these areas. Now, the nice thing about AccuTite, it's a very efficient heating. You're going to see that this treatment is actually quite quick. And the machine, I'm going to show you the settings momentarily, but essentially we preset our internal temperature. So this internal cannula has a thermometer telling us our internal temperature, and then we're going to measure our external temperature. So it's going to give us a gradient of what temperatures we're at inside and outside, so we can give an efficient treatment. So we're going to go ahead and treat each one of these areas, reach our target temperature, stay there for a little bit, and most importantly, we want to hit our internal temperatures, because this is what's going to contract those fibroseptal networks, trigger the neocollagenesis, and give us an ultimate contraction. So we're going to start with the lower lid here. And I have my foot pedal here. Now, if I trigger the device and it's outside of the body, we're going to hear this noise here. So that means that the device is uncoupled. The device is identifying that it doesn't have energy, it doesn't have a conductivity between the two electrodes. So we're going to go ahead and show you the device settings. So here you can see on the right side, we have our actual temperature. So if I pinch the internal electrode, you're going to see the temperatures change. So that's one way to test it. If I put my finger on the external electrode, you're going to see the external temperatures changing. Now on the left side of the screen, those are our cutoff temperatures. This is a temperature, these are numbers that we put in. So our external cutoff temperature is going to be 38 Celsius. Our internal cutoff is going to be 68 Celsius. The treatment time is 120 seconds. Which means that after 120 seconds, we have to kind of re-hit the foot pedal. And then you're going to see here how we're going to do this treatment. So I just put the internal cannula through the access port that we made with the 18-gauge needle. I'm right in the SOOF, that's where I want to be. And I'm going to activate it with my foot pedal. Now I'm cantilevering down. Now the single beeping indicates that we're kind of far from target temperature. Soon we're going to hear a double beep, and then a triple beep. That indicates that we're approaching temperature. So once we hear a fast triple beep, that means we've reached internal target temperature. Then we're going to hear a slower triple beep. It's going to indicate that we reached external target temperature. So here's internal. So now we already reached internal target temperature. It's a small area. And then we're going to slowly reach external target temperature. Now we want to stay about a little bit of a distance away from the entry port so we don't keep heating it. You doing okay there, Rob? Mm-hmm. Good. So she's comfortable, awake and comfortable for this. So again, I'm kind of staying away from the entry port, and soon you're going to hear we're going to hit our external target temperature.
So if you had a gun put to your head, Erez,
yes,
and you had to pick the internal or external, obviously we want both.
Yeah.
Which of the two is the one that you go with?
Internal for sure. Now here you see the slower triple beep. That means we've reached external target temperature. And I like to stay at that temperature for about 30 seconds or so. So we get a nice even heating. Now if we had a FLIR camera on this, you would see that it would be white volumetric heating of the area. So you can see the lower lid is a fast treatment. I mean, that we reach temperatures pretty efficiently there. So internal, to answer your question, Chris, internal target temperature is key. So I'd like to go back and forth here a little bit. We're going to go ahead. Now we're treating above the nasolabial fold. So the fold is actually the lower line here. So we want to kind of efface the fold. So I'm treating right above it. I'm cantilevering the internal electrode down. And here we go. We're going to treat this row. So you're going to see we're going to hit internal target temperature with the fast triple beep. Very efficient heating. There's not very much tissue here to heat, so we're able to really get a nice efficient heating. She's comfortable, awake, and this is, frankly, I like this far better than fillers. I mean, I hate putting fillers in the nasolabial. I don't think it looks natural. I don't think it moves naturally with the face. So, and frankly, I feel safer doing this because I don't have to worry about, injecting intravascularly. Patients get minimal to no bruising. Frankly, usually no bruising, because it coagulates any kind of small vessels, so we don't have to worry about bruising. It's
Plus
comfortable.
the lymphatics are preserved. In your study that you show with the spy camera.
Yeah. Well, I'll tell you something
fillers.
interesting about that. A lot of Kami Parsa in Beverly Hills, who's an oculoplastic surgeon, sees a lot of patients. He named this. It's called FARI, post-hyaluronic acid recurrent eyelid edema, and he sees a lot of patients that get tear trough fillers and recurrent edema. And part of his treatment protocol is using Morpheus and AccuTite in the lower lid. And that benefits him because it improves the lymphatic drainage that the fillers are obstructing. So we've actually investigated that, and we have a publication in line in press right now regarding that. So radiofrequency, contrary to some other people's beliefs, actually improves lymphangiogenesis and vascularity and angiogenesis, which makes sense from a basic science standpoint.
But kudos for you actually demonstrating that, because we kind of suspected that, but we need to have.
Thank you. Yeah, it's one of these things where a lot of the older plastic surgeons who kind of don't like technology will always critique it, and they may say, well, I've done facelifts and there's more scar and this, but really when you look at it, it's almost like delaying the flap because you've actually improved the perfusion. So it's quite the contrary. So here you can see we've reached a nice temperature here in the nasolabial fold.
Once again, it's a sophisticated audience because almost all users, but there's that fast beat that we're really looking for the internal.
Exactly. So we're looking at the fast beeping. That's the internal target temperature. And so we've treated the lower lid, nasolabial. Now for the jowl, in her case, because we're using AccuTite, you doing okay there, Robin?
Yeah.
Good.
Feels like a warm towel.
Feels like a warm towel. Not quite a spa, but not far. So we're just going to pre-tunnel a little bit. Now we
Can
did
you
zone.
talk about patient selection when
Yeah.
you're treating the lower lids, especially?
Yes. So for patient selection, I think age is critical and skin elasticity is critical. So if you try to do this on a facelift patient, I don't think it's going to work out well because their skin elasticity is just burnt out. You cannot, I've seen people try to apply this technology on just patients that are just simply too old. Now, if you hear that noise, that was a temperature surge, and what that means is that the temperature went up a little too quickly. Right there, you hear that? So I just got to go in a little bit of a deeper plane. The device didn't fire because it sensed the temperature went up too quickly. But so if you do it on patients that are really facelift candidates, it doesn't work. So really, you want patients in their 30s, 40s, 50s with moderate laxity, mild laxity. Where you feel that a facelift would be overkill. That's really key. The technology works excellent in the right patients. I think patient selection is really, the treatment itself is very easy, actually. It's not a technically challenging treatment. It's patient selection that's key. You don't want to overpromise for patients that need an excisional procedure. For the lids, I would say if you have a moderate tear trough area, you can really treat the SOOF nicely and just contour that area. I like to combine it with fat transfer. I think that's a benefit to patients.
We remind the audience that all these videos will be available on InMode University's website. And we can also refer to Dr. Sean Paul, who's an oculoplastic, had a nice cadaver dissection of the septum and the lower lid as well, among other videos. So what we're going to do is Dr. Dayan's going to actually do the left side so we have an even better camera angle.
Yeah.
And then probably do the left axilla and knee in that.
Yeah,
order.
perfect.
Yeah.
So I'm going to let you hold that for a minute. Okay, so I'm going to switch sides here.
Great.
So
far.
we have a question about Morpheus.
Yes.
Do you adjust your settings is it safe for bearded areas or do you adjust your settings to prevent alopecia?
Right, so I've seen pictures of other people, InMode slides actually talking about alopecia. I have never experienced that personally. I don't know what your experience is with that, Chris. I haven't seen alopecia from any treatments radiofrequency related personally.
I've only seen case studies where I believe that the internal probe was too superficial.
Yeah.
So if you could reemphasize that the importance of having some intervening distance.
Right. So let's remember that the way radiofrequency is working is through heating of the fibroseptal network. So this is called Ohm's law, and we're passing an electrical current from the basically pre-fascia level, so pre-SMAS, pre-platysma. We're above the fascia. And we want to heat these fibroseptal networks and allow them to contract the skin envelope. So the goal is not to heat the skin. The goal really, as you were saying, Chris, is to heat internally the fibroseptal networks. So the internal cannula should not be, even in the eyelid, which is thin, you can't really see the internal cannula. It's not that superficial. So you really shouldn't be bumping up against hair follicles. The heat should dissipate by the time you're kind of there so that it's not damaging those areas.
How about the Morpheus8 on bearded individuals?
I've never seen a problem with that. I think the Morpheus is a fantastic treatment. It's very safe in all Fitzpatrick types. I've never had a problem with a darker skin patient. So the Morpheus is great in combination or in isolation. This is a real opportunity to do Morpheus because the patient is too messed. So I'm not worried about her comfort levels here. Now the lower lid is thin, so we want to make sure that we're deep enough here, and we like to stay right on the periosteum here so that we're not too superficial.
If you had a ballpark an estimate of how thick that tissue is between the two electrodes, what would you guess?
It's probably about 0.5 centimeter, 0.8 centimeters.
Pretty generous amount of fluid in there.
Yes. Great. So we reached target temperatures here. I wish you could feel that it's warm, but she was totally comfortable through it. Now nasolabial. So we just got to find our access point. We just pre-tunnel a few steps. cantilever down.
How much time before a patient's social engagement would you schedule this type of procedure?
Great question. So I think from a long-term bruising, swelling standpoint, it's not very much. Of course, she's going to look funky today and probably tomorrow just in terms of the amount of tumescent we used, but it's not a long downtime procedure. The Morpheus in combination will give you a little redness for a couple days, maybe a day or two, depending on how aggressive your settings are. But overall, it's a very minimal downtime procedure. To be honest, whenever I've done fillers and gotten bruises, I think they have more downtime than this. So this is going to look a little more dramatic for the next day or so because of the tumescent, but generally speaking, it's a pretty minimal downtime procedure.
So we're really focusing on internal temperature here, which I agree with. How about the business aspect? Without getting specific about numbers,
Yeah.
how do you package or your manager presents because you're offering a tremendous amount of options for patients, which is great, but also can be, for those of us who are starting an aesthetic practice, for the outside the operating room or a minimally invasive arena, what's your general approach to like packaging deals or adding on other procedures on top of the basic one?
Right, so it's a great question. So I think there's a lot of ways to look at this. You know, for us in plastic surgery, we love doing surgery. But once you understand all the things involved in that in terms of anesthesia costs, operating room costs, just downtime, there's a lot of issues with general anesthesia. And it not only affects your ROI, but it also affects patient comfort. You know, patients have to come in, especially now with COVID, they have to get COVID tested. They have to, for us here, a lot of the centers are requiring patients to quarantine pre-surgery. It's a lot to go through. And I found that a lot of patients don't like, even though general anesthesia is safe, they don't like the effects of it. You know, nausea, all these other issues. And not to mention costs. So, you know, just to walk into an operating room, you know better than me, is a few $1,000s before you even get started. So from an ROI standpoint, I think this treatment serves a lot of roles. Number one, we can do it comfortably in an exam room. I mean, that's basically how I started my practice. We were doing these procedures under local anesthesia and in a small exam room. It doesn't require a big footprint. You don't need an anesthesiologist because the patient's awake and comfortable under local. And you're offering them a significant soft tissue contraction benefit without incisions, essentially. So it's kind of a win-win-win. As a young plastic surgeon, this has been key to our practice because other practices don't offer this technology at this level. So patients prefer it, and it's also been better for us.
And for the body contour, we found no compromise in terms of volume of resection. There's quote-unquote compromise I found is if the lidocaine load is a little bit high, we break it up over several days. I've never in 17 years had lost a patient because it's all about safety and comfort. And they say, okay, doc, I understand you're breaking it to 2 short periods rather than 1 long one.
Yeah, I totally agree with you. I mean, we do lipo procedures with ultrasound, with radio frequency, all under local very comfortably.
The minimal
Sure, why don't we put your chin all the way up
compared to the hospital or ASC.
Exactly.
Can you
Take
talk
a
a
little
little
more,
bit
Joe.
about the amount of energy you're giving and how much time you wait once you get to your target temperature?
It's a really good question. So there's no right answer to this. You know, radio frequency works through what's called an Arrhenius equation. And what that means is you can either treat at a high temperature for a short period of time or at a lower temperature for a longer period of time and gain the same contraction. So here we're doing submental area. So
that's a Harvard coming out with Dr. Dayan.
So there are clinicians that'll treat at higher temperatures for shorter time, or more modest temperatures for longer time. But I think at these temperatures, 38, 68, I like to hit target temperature and stick around there for 30, 40 seconds. And the reason I feel comfortable doing that is because I know the machine's not overheating. It's just maintaining that temperature. So I'm not. You know, I look at this technology like a Ferrari. It's all about control, you know, otherwise it can be dangerous. So some of the other technologies that hit very high internal temperatures, they don't have the same temperature control, so you're a little more concerned about how long you're treating for. Here, I'm not really worried about it because just because it's triple beeping doesn't mean it's continuously firing. It's just maintaining my temperature.
How much energy have we used so far?
So we are at 1.6 kilojoules. Now, one thing I will say is a lot of people ask, oh, how many kilojoules do you need per area? You feeling okay there, Rob? Mm-hmm. Good. And the answer is I don't know, because it depends on a lot of factors. It depends on the patient's skin temperature, it depends on the amount of tumescent you use, the temperature of the tumescent. So I'm really focused on reaching target temperatures and staying there for a little while. But you can see AccuTite on the face is very efficient. I mean, we're reaching temperatures quite quickly here.
Yep.
What do you do for post-treatment guidelines?
So one thing is we don't really use ice post-treatment. So here you can hear we hit external target temperature here. So I don't like to use ice because there is a volumetric heating that we want to maintain for a period of time after the treatment even. I'm going to have you look all the way towards me.
How about non-steroidals? I don't like to use non-steroidals in the immediate post-op.
Yeah, that's another consideration. Some people feel, and I agree with you, Chris, that non-steroidals we want an inflammatory effect here. So we don't want to necessarily blunt that in a meaningful way.
What about a face wrap?
So we do a face wrap just to get the kind of tumescent swelling down. And I also think that some compression is valuable to offload the skin, especially after we do lipo, which we're going to do.
How long do you do that for?
It depends on the case. For a case like this, maybe a couple days to a week. You don't want to inconvenience the patient too much. You kind of just want to get the tumescent effect down.
I'm going to steal your term offloading it because I think it's important. Even if, say, a patient does not need neck lipo, I still will tunnel.
Right.
To kind of get those trabeculae that you showed on that slide with the tummy tuck.
Exactly.
It's important for it to get the contraction.
Yeah, we do the same thing. Discontinuous undermining has a lot of benefit on its own. But between that and the radiofrequency, there's definitely advantages to discontinuous undermining in combination.
Totally agree.
So this is a very popular treatment for patients, and you can see it's not very challenging for us. I mean, we're just kind of comfortably here performing it. It's not a big deal.
So when do you decide to do Morpheus8 on top of the face or tight or AccuTite?
Honestly,
what
I
are
think
your
it's always
Yeah.
my preference. It's just a question of patients kind of, frankly, a lot of it becomes a cost consideration sometimes, but it's usually preferable. We always do the Morpheus in series of 3. I find that a series of 3 is always best. But patients love Morpheus. We have patients that travel, 2 hours just for Morpheus because they really see the benefits of it.
I have to agree with that. So it's almost like a second bite of the apple for tightening from a different direction.
Right, and I think it's great on its own. Morpheus, just to talk about some kind of, if I may, some off-label uses. We use it for a lot of things. The dermatologists have written about using it in cystic acne, hyperhidrosis. So Morpheus is a very versatile technology.
Do you use the ablative or resurfacing tip for that indication?
So normally when I'll do a series of 3 for just rejuvenation, I'll include at least one resurfacing tip. So the resurfacing tip comes out about half a millimeter. It's uncoated. So this is just a very straightforward cannula. It's 14 gauge. It's just a little Mercedes tip cannula. And I just want to kind of do a little handheld lipo here. It's one of my things I like to do. So this is, let's see if we can use this access port. Let me see a little 11 blade there for a second.
What has your experience been with long-term induration of the access points, particularly along the anterior submandibular and submental sites?
I haven't really had long induration. Sometimes you may see a little nodule, but that usually resolves. I know that other people sometimes will inject a little Kenalog. So here I'm just undermining here with a small 14 gauge cannula just to make a path. And I like doing a little handheld lipo. I think it's just the perfect. There's a small amount of volume here. We just want to kind of contour. So I'm just kind of undermining before I do the actual lipo.
And then do you slightly decrease the temperature using AccuTite versus FaceTite?
I use the same temperature settings. I think the benefit of FaceTite is you just hit kind of a wider area.
You're getting a little on the outside.
At the edge there? Okay.
Yeah, the length of the internal probe for the FaceTite is 10 cm and 6 cm for the AccuTite.
6 cm for this, right.
So it's about a reach thing. Obviously, to do face and neck optimally, we do 2 devices, but that's your choice because there's 2 disposable costs. Obviously.
Yeah, I think in a patient like this who really doesn't have very much laxity in the inferior neck area, AccuTite's perfect. I mean, we just hit this area that she needed. Just doing a little handheld lipo just to thin this out. She's going to have a beautiful result. It's almost too easy for us because we do the radiofrequency, we do a little lipo. It's fun, it's easy. The patient's walking out of here pretty comfortable, You know, it's just a fun treatment to do. Like, and you can do a lot of them in a day. It doesn't require a lot of turnover of the room. It's not messy. You feel that a little bit there, Rob?
I mean,
So do you have,
Stay up here.
Just at the bottom end side.
Okay.
do you have any other tips to avoid neuropraxia other than avoiding the DAO triangle?
Yeah, so ample-tumescent, I think, is an important component of that to act as a heat sink, because there is a little bit of a heat signature to that probe. So ample-tumescent, making sure that your probe is right above the SMAS or platysmal level, and avoiding that triangle. The way I showed you to mark it is very generous, meaning if you're using the marionette line, you're kind of far enough away. And the way we treated was from the pre-jowl out, and we stay a little bit of a distance from the entry port. So between all those things, we're kind of really avoiding where the marge is becoming superficial. And the other thing I would suggest in the beginning, at least, is assess the patient's marge before the procedure, of course, after the local, and after the radio frequency. At least it'll give you a sense of whether the local contributed to that. So you see, honestly, it doesn't take much fat removal in the submental area to create a nice contour.
Can you explain why you do the liposuction after rather than before the AccuTite?
Yes, great question. So I always like to do lipo after because a couple of reasons. Number one, if I do the lipo before, I'm removing fat, I'm collapsing the fibroseptal networks, and I'm removing tumescent. And tumescent is a really key component to the conductivity and safety of this treatment. So I don't want to do that. So what I want to do is really optimize the tumescent effect, make sure the fibroseptal networks are maximally extended, and then I just do lipo after. The only times I do lipo before is if it's like a really heavy patient, I'm doing their abdomen, and I kind of want to debulk a little bit before doing the treatment.
or you're planning to do fat transfer because you don't want to kill the fat.
Yeah, exactly. If you're going to fat transfer, it's better to do it to harvest some of that fat before it gets damaged. Although, I don't know what you think about this, Chris, but I know a lot of people that do ultrasound lipo fat transfer that fat.
That's fine. There's a couple studies that shows if you use ultrasound at 70% or below, that's a feasible thing. But RF, Spiro and I actually did, we didn't ever publish it, we looked at laser lipolysis, ultrasound lipolysis, and RF lipolysis.
Let's take a local.
And all of them, with the exception of ultrasound, killed the fat. So if you want to harvest it, don't heat it first. It's a bovie. I mean, it's not surprising.
Right, exactly. So you can see that's basically it. What I want to do is I'm just going to do a touch just of the gel, just a little bit of lipo there. Not very much at all. Just to kind of contour the jawline just a little bit. Let me see a blade there for a second.
It's kind of like a modified Ravati that you're doing.
Modified Ravati. What's that? Okay, yeah, we're going to do the gel, so you're not going to feel this very much. Okay. Any other questions?
A couple Morpheus questions.
Sure.
Would you use the
okay there, Rob?
resurfacing tip on a Fitzpatrick 4 through 6?
You can. I don't have a problem with that. I do think pre-treatment with a little quinone, a little sensitive there. Okay, I'm basically done here. So you definitely want to pre-treat those patients. But we've done it before many times, and it hasn't been an issue for us. Have you have any different experience there, Chris?
We don't have a busy aesthetic practice, so I generally don't. I prefer those patients elsewhere, but I've heard from friends like you a lot of success with that. And we do a ton of tightening, but the ablative tip I tend to not use as much.
Yeah, I would say just start off on a test an area at a lower heat. Make sure you're safe. Safety is the number one thing. And the benefit is you can always test an area, see how that patient responds specifically. But back in the days when they were doing Fractora, there's an article, I think by Judith Hellman, talking about using the uncoated Fractora tip on Fitzpatrick type 6 patients for acne and acne scars, and they didn't have any pigmentation issues in that study.
I think the key is low energy. In my experience, that's really kept safe.
Yeah.
Low energy.
When in doubt, use low energy. The worst case scenario is you have to do another treatment later, and that's it. So.
Yeah, you taught me to do lower energy and more passes. Yeah.
More passes and more treatments.
Right.
It's like driving a 200 horsepower Camry in a quarter mile. You'll get there, but instead of a funny car, you're gonna get there a lot quicker, but less control. Erez, if you don't mind, if you do patient left, that would be great.
Yeah, let's do that. So we're gonna. What I'm gonna do is I'm gonna numb her axillary roll, and then we'll go back and do the Morpheus. If that sounds good to you.
Yeah,
so I'm going to have you keep your arm down. So let me have a marking pen there for a minute. So there are certain areas that really bother patients a lot, and I think axillary roll is certainly one of them. And then, so we're going to come pan down to the armpit area here. and show you the axillary roll area. So really the axillary roll is kind of this area. It drives people crazy.
Especially with the swimsuit tops and push-up bras in females, they kind of
Yeah,
exacerbate that.
it's just an area of adiposity that's very bothersome to patients. Good. I'm just going to kind of show you this area. Perfect. So I'm going to keep your arm down. So what I like to do is kind of access from the apex here. Same thing, we just put a little local, a couple cc's of local right in that area. It's a very easy treatment to do. And I know, you know, Aviva Preminger in New York does a lot of these, is known for it. It's funny, you know, once you start doing a couple of these, just the word of mouth, because people talk about this with their friends all the time, will cause everybody to kind of flock to do this. So a little same thing, 18 gauge and tumescent, 60 cc syringe. It's just going to infiltrate this area. Now, you don't really want to see skin changes, peau d'orange on the skin. You kind of want to be deeper to that. One thing I learned in terms of local technique from Dr. Chia and Dr. Theodoro is just go slow, right above the fascia.
Low and slow, like
Low and
barbecue,
slow,
like
yeah.
barbecue. Well, I see a lot of familiar names in the text box. Thank you for all your questions, and we'll try to get to all of them. Lisa's
Let me see the
gonna answer
tumescent
in
camera
turn.
there, Rosa. You doing okay, Robin?
So one suggestion from Martin Ray is they've experienced some darker skin type patients developing PAH following Morpheus8. They recommend treating with HQ in order to reduce the risk.
Yeah.
In my practice, I've treated with 4% twice a day for about 4 weeks prior and then about 4 weeks after. Do you do similar?
Yeah, same thing. One thing you want to be cautious about is just make sure you're doing the hydroquinone appropriately because you don't want to get rebound hyperpigmentation. You have to take breaks from it.
What's the longest duration you would do it before?
I do it the same way, honestly. So I haven't really deviated from that at all.
What about your experience with like IPL or lasers for those other considerations?
Yeah, you know, to be honest with you, Chris, I have somebody doing the IPLs for me who's much more experienced with it. But I will tell you, like, as far as concern over pigmentation, I'm much more comfortable with radio frequency because I don't worry about the pigmentation as much. I think the lasers are just more powerful. So you just have to have a lower threshold for reducing the energy.
Yeah, for me, I'm just a dumb surgeon. I don't understand it as clearly, but RF I understand.
Right, yeah, RF. You know, the nice thing about RF is it's powerful, but I feel that it's safe. As long as you keep a couple factors in mind, just maintain a deep internal cannula of the RF probe, maintain your temperatures appropriately. It's an easy treatment to do. Technically speaking, it's not hard. So now we're going to do the axillary roll. Now you're going to see why we chose AccuTite here. It's the perfect size. We're just going to treat this area here through one access port, and we're just going to go row by row.
Can you tell me how often do you use AccuTite and Morpheus, especially under the eyes? All the time, most of the time?
Well, almost all the time, because now that we have Morpheus Prime, it allows us to get to small areas like above the lip, lower lid. So the Morpheus Prime has been a nice addition. So I do think it's definitely beneficial. I mean, of course, I think the AccuTite on its own is very powerful, and I think Morpheus just adds some power to that.
Can you talk about your tumescent composition again?
Yeah, so you know, I use a little bit less local than Dr. Theodoro and Chia. I use typically anywhere from 30 to 50 cc's of 1% Lido with epi in a 1 liter bag. It depends. You know, if we're doing a face case, we can use a higher concentration because we're using less volume. But for body cases, I like to stay well below that 35 mg per kg kind of limit. I know that a lot of the dermatologists have written about using 50, 60, 70 mg per kg. I'm just not comfortable with it personally because I don't want to have a problem. I mean, we do have intralipid available. I've never had to use it, and I hope to never need to use it. So I like to keep it pretty safe. I know that Dr. Chia uses the A solution, they call it, which is it's 1 gram per liter.
0.1%. So if you're saying you're using 50 cc's of 1% per liter,
Yeah,
that's about 0.05.
right. So you would use 50 cc's of 2% or 100 cc's of 1%.
Yes.
Right.
It's a relatively high concentration, but as long as you adhere to the SPS 35 mg per kg, you're good.
You're good, right. It is important, I'll tell you, as a person that reviews medical board cases, lidocaine doses are very important. You want to make sure that there's epi in there. You know, the nice thing about radiofrequency too is it minimizes your blood loss when you're doing bigger lipo cases, similar to ultrasound. So there is some advantage there as well.
So are you varying your depth here on the trunk area as different than the face and neck?
Yeah, so I like to stay right above the fascia. And it's interesting because you'll notice as I'm talking with you, I'm a little superficial here and so you'll hear the temperature surge because it's identifying that the temperature is a little high over here because I'm not deep enough. So I kind of want to go right above the fascia level, cantilever down a little bit, and make sure I'm treating that area well.
Will you use another counter incision closer to her?
Yeah, I'm going to make one right here to kind of treat the rest of the area. But you know, it's such a minimal access point. It's kind of nice.
Great.
Yeah, so the axillary rolls are like a hit because especially, you know, spring, summertime, everybody notices that and wants to get rid of it. So it's a really nice area to treat. Do a little lipo. You know, I think you're going to get a benefit just from the lipo alone. So the radiofrequency definitely just magnifies that effect.
I agree, because if you do a breast case, you know, a hog fracture or something like that, you confront the breast bone appropriately, you're going to get that accentuation of fat.
Right.
You're there, you all suck it down. But I do think the RF does help
For sure.
qualitatively, aside from the contraction. This makes it look less.
Absolutely. And it's a fibrous area. So, you know, interestingly, the more fibrous the area, the more collagen bands there are, the more of an effect you'll get. Like a lot of patients that have failed Kybella treatments do very well with RF because there's a lot of scar tissue in there to remodel. So it's kind of a win-win because those patients have tried other things. They've tried cool sculpting, they've tried Kybella, and haven't seen an effect because they're only those technologies are only focused on fat, where we can really impact skin as well as fat with lipo.
So we're under SFS here in the trunk area, which is really good.
So here you see we're just doing see how nicely the fat comes out there, very minimal blood. Just a little handheld 10 cc syringe, very low tech but effective. It doesn't take much volume here. You know, 2 of these and we're kind of good. So you know, you can easily do 4 or 5 of these in a day comfortably. And we're treating.
How would you target this in your social? You're a guru at social media, at least tasteful social media. There's others to be desired, but yours are always informative, easy for patients to understand, and also gets the message out that this can be attainable for almost anybody.
Well, thank you, Chris. I would say the following. You know, as we've gotten busier, plastic surgery, I think it's important to educate patients because patients want to know how does it work, what does it do. And the nice thing is this technology is very easily understood. You know, we talk about heat. It's a shrink wrapping concept where we're going to heat an area, we're going to shrink wrap it over time. And I think the FLIR camera, the nice thing is, you know, a lot of times we want to show treatments, but we can't show abdominoplasty. It's going to turn people, you know, if I saw an abdominoplasty on video and I was considering it, I would take it off the table immediately because it's a scary thing to see. This is not scary to show people. You show people minimal access, you show them a little heat signature on the FLIR camera. Most importantly, you show them the before and after, and that's the formula. There's not much more to it. I think you just have to show the process. And the nice thing about these technologies is the process isn't that scary. So you can show it, and you don't have to be concerned about how people may take it. You know, initially when we were showing rhinoplasties and abdominoplasties, what you find is that people are spectating. It's not the people that want to come to you, they just want to see surgery. So let's do the other area here. Let's do the knee, yeah.
Let's do the left knee, please.
Absolutely.
Yeah,
so we're going to...
well, while we're getting that ready, I also want to comment, like, in terms of along those lines, do you take your own?
Yes, good up.
Do you take your own pictures? Do you source that out to pros?
You know, I like to take my own photos. I think it's important to control that because, you know, just for consistency, putting tape on the floor, making sure that your patients are standing in consistent positions, the lighting is consistent, I think is critical. I know, Chris, you're better at this than I am in terms of photography. So the areas that we want to treat above the knee are really localized. So here's kind of the knee border. And we kind of want to treat this general area here. Now this is another area that when you can't see it so much when she's sitting, but when she's standing, this is a really problem area because it kind of hangs over the patella. And there's no real good surgical solution for it. You can't do a knee lift,
Right.
really. Frankly, I don't even really like thigh lifts because it's just you're working against gravity. And when you do that, you'll usually lose, not to mention the incisions and potential complications there. So,
Well, there's that famous celebrity that had a excisional procedure, I believe, a crescentic skin excision suprapatellar.
oh, is that right? I didn't know that.
Yeah, well, you're young. This is a long time ago. So obviously did the trick for the laxity, but that was a pretty morbid incision for most.
Yeah, it doesn't seem like a good idea because there's just a lot of movement there. So we're just going to, same process. The nice thing is that you're just basically doing the same process everywhere. So we just infiltrate a little bit of local. We just go.
Would you like to table up, Erez?
Yeah, please. Or I can even bring this stool around if you want. Either way.
No, what makes you comfortable?
Yeah, we can just do the stool because this way we're going to go back and do Morpheus. Now, once you know you're in the right tumescent plane, things just open up. It's a very natural. Thank you very much. It's a very natural. Thank you. Process. So low and slow. Now we're going to use a tumescent cannula here. So let me take a little 15 there for a second, Rosa. Thank you.
While you're doing that, Dr. Forley has a question.
Hi, Dr. Farley.
I know. Hello. You weren't using the gliding technique, but rather heating repeatedly at the same point. Is that your practice with face tight and body tight? And if so, do you have any skin concerns using that approach?
So we like to go row by row. Now, don't forget the machine is smart enough to not overheat. So as long as I'm kind of moving, like I don't like using a stamping type technique because I'm afraid that I'll overheat those areas. So as long as you're moving, I think you're actually quite safe and fine. And I think depth is one of the most important things. You want to make sure you're not superficial because the heat is coming from the internal cannula. So depth is key. As long as you're deep, you're safe. And you're also heating those fibroseptal networks there. So I think you're safe as long as you can't see your internal cannula at the skin surface, right under the skin surface.
Keep it moving, stay deep, and don't heat too close to access incisions.
Right.
That's the.
And I think being systematic is important too, because if you jump around too much, then certain areas don't get heated enough, and then the other areas are cooling down, and you don't quite know where you're at. Now, another thing to tell the patients when you do like a full face tight or AccuTite is that they're going to feel like their lip is weak. They're going to feel because of the local. So if you tell them ahead of time, they might be drooling for a little bit until the local wears off. That's better you tell them ahead of time. So my fault for not telling you that, Robin. So you see it's not very much tumescent. We're probably going to put in about 60 to 80 cc's per side. Really get a nice tumescent effect here. So between this, the axilla, and the face, I mean, you're really hitting most of the high-value areas for patients.
Absolutely. We're really appreciative of the patient, of course, and you showing all these areas. So when we show, if you don't mind, we can show some of the AccuTite here.
Yeah.
But how about the subtle areas that we'll go back to the face and do the Morpheus in the face, because most of the audience will know about the body, but the face, there's some nuances that you can share with the audience about, your little tricks to get the right angles, the bony prominences, that kind of thing.
Yeah, absolutely. So we're going to do a little AccuTite here. So as you can see, I think, the way I look at it is most of the body is pretty straightforward in terms of radio frequency. There's not really many danger zones. It's the same concept. You're above the fascia, you're amply tumescing, and then you're performing bipolar radio frequency of the fibroseptal networks. In the face, you want to be wary of the end branches. So any kind of frontal branch or marginal mandibular. Those are the areas that are really potentially problematic from a neuropraxia standpoint. Now, as we were talking about this earlier, even lipo alone of the lower face will potentially cause a neuropraxia just from the traction. So that can happen with lipo alone. So we just want to be, aware of it and make sure that the patients know as well that can happen. It luckily doesn't happen often, but it can. So here I'm just going to go row by row and just demonstrate the treatment.
While you're doing that, what would be your ideal treatment sequence when combining a series of Morpheus and AccuTite? Meaning, would you start with Morpheus monthly and then finish with the combo?
No, I think I would start with Morpheus, just like we're doing today, basically, and then continue with 2 more Morpheus treatments afterwards, probably about 4 weeks apart. There's a little variability there. Some people do it a little sooner, some people do it longer is not a problem. But I do find that if you do it longer than 4 weeks, people start losing interest. The problem with radiofrequency is you just have to reiterate to the patients that it's a slow-moving train. It takes time. It takes time to kind of get those results. So it's, you just have to get good photography so that, because a lot of times patients will forget where they started from. And it's important to remind them.
How about just, do you package it as a package of, say, the way we do it, Spiro and I do, package of 3, plus spread over the same time period as you, over 30 days. And then a maintenance one at, say, 6 and 12 months.
We do exactly the same thing. We do the exact same thing. So a lot of people ask, like, how often do I need to do Morpheus? I don't have a great answer for that, but we have patients that come annually, not infrequently. I don't think it's a bad thing. I do think, we've seen histologic studies showing improvement in collagen thickness. I think patients really appreciate that in terms of the overall effect.
Yeah, I think that's what, when we go and talk to our friends who are doing this in other parts of the country, it's pretty much the same thing.
Right.
Yeah, we welcome any comments if anyone does anything differently.
Yeah, Morpheus is a costly treatment, so I think for a lot of people, doing it more than annually would probably be somewhat cost prohibitive. But I also don't think you really need it more than annually for most people.
Yes.
Okay, so maybe we go up to Morpheus now that we're kind of talking about it. How does that sound? We'll come back and complete this.
Appreciate that.
Good. So let's talk about Morpheus a little bit.
How
Any
about the
questions?
tips? Do you use the same tips, or obviously you want to be cost effective in the practice, but you also want to have the right type of size, like for 12, 20, or 40.
Right. So normally I'll use the 24-pin tip. It's kind of the standard tip. I'll probably use that depending on the patient. So if the patient is a younger patient that has primarily kind of surface concerns, we'll do 2 resurfacings and 1 24-pin. As opposed to a patient that may have more skin laxity, we'll probably lean towards 1 resurfacing and then 2 24-pin tips. So we're going to switch over to our settings here.
If you could show the screen, Ryan, please.
And we're going to show you kind of how we set the Morpheus. Now, there's no real right or wrong answer here, but I'll show you kind of what we do. So in a patient like this that's too messed, she's going to be comfortable. And now I'm going to do this at a couple different depths. So we're going to start off at, let's say, a 3 millimeter depth and an energy power of 35. If the patient is just under topical, I'll usually start at 30 because it can get sensitive. Now there's cycled mode and there's fixed mode. Cycled mode means every time I hit the foot pedal, the needles are coming in and out. Fixed mode means the needles stay out and just pulse. I prefer cycled mode. I think the injury of the needles is beneficial to our result. And then repetition, I usually put it all the way up
1.5
to 1
ppс.
Yep, and then we're going to hit standby. So here you're going to see, here's the handpiece. So you can see the needles coming out.
Do it over there.
Show you right here.
Against the blue, sometimes.
Yeah. Great. So you see the needles coming out. So they're 24 pins. They're coming at 3 millimeter depth right now. So we're going to go ahead and treat her face with this. The areas that we treated, we're going to go ahead and do with Morpheus. And we're going to do it at 2 different depths. Sometimes people do 3 different depths. I know, Lisa, your practice is to do, what, about 1,000 pulses on the whole face? So,
1,000 to 1,500.
Yeah, so you can get pretty aggressive with the number of pulses. Okay, so we're going to go to your face here. So I'm going to have you close your eyes here for me, Rob. So a couple things. With the Morpheus, what we want to do, first of all, is make sure that the headpiece is dry. So I'm going to have a little gauze in my hand here just to make sure that I'm keeping everything clean. We removed all the gel. If you're prepping with alcohol, you have to make sure that it's totally dry before performing this treatment. I've never seen the Morpheus have any kind of, what would you call it, it's always in contact, because if you treat the patient, it won't fire unless it's in full contact. So I'm going to go ahead, let me see how I can give you the best angle here.
That's great.
So good. So we're going to go ahead and treat here. So you got to make sure there's good contact. Sometimes you can pinch the skin just to make sure you're bringing it up to the device. Because the device, the metal faceplate, is where the energy is coming to. So you want to just make sure you have good contact. We're going to do 2 pulses. And then we're going to 50% overlap.
Can you tell us the difference between stacking and randomization and et cetera?
Yeah, so stacking means that you're doing the pulses in the same location. So basically I'm double stacking, which means the device is down, I'm hitting 2 pulses, and then I'm going to do a 50% overlap.
that translates to a more aggressive treatment because the tissue doesn't have time to cool
Right.
directly in between.
Exactly. So you're just like exactly, just like you said. You're basically stacking the heat on itself.
Some of our colleagues go 3, 4, even quadruple. Have you
Yeah,
seen more
honestly, I
studies?
do that routinely. I just for the purposes of this, I didn't want to show something too aggressive, but you can
Right.
easily do 3 or
In the
4
right
pulses.
areas, right?
the right areas.
Yeah, in the right areas.
in
As
the
long
right
as
areas.
yeah, you can easily do 3 or 4 pulses.
So if you had a patient that had FaceTite and AccuTite in terms of multiple areas, similar to this patient today, how do you end up pricing that? Do you
It's
do
a
it
good
per
question.
area or per time?
It depends. So I would say if you just wanted to do like an individual gel, for example, it's going to be something, you know, in our practice, it's somewhere in the 3,000 to 4,000 range. If you're going to do a full face, it's probably about 7,000, 8,000. For like basically what we're doing today would be about 7,000 or so for the AccuTite, and then you would add the Morpheus, which we charge about 3,000 for. So it can get costly, but you feel that a little bit, Ro?
Yeah.
Okay, we're going to go in the submental area.
We appreciate you sharing the actual numbers. That's very kind of you.
Yeah.
But it obviously adjusts for regional differences.
It just depends
Yeah.
on the market.
Yeah,
You know, I
exactly.
think, frankly, in a place like New York, you probably have to charge a little less because there's just more
More providers.
more
yeah.
providers. Yeah, here
We're
is
gonna
a
move to
little different. But you know, it's like everything else. You have to deliver the value. Once you deliver the value, you feel that a little bit? Okay. We'll move over here. Take a look at me, Robin. How's here? You got to tell patients that they may smell a little bit of
How about the carbon buildup on the pins? You'd stop and clean them off once in a while?
Sometimes we're kind of not doing enough pulses here, but yeah, every once in a while we come and just kind of wipe it off, make sure that it's clean.
Those outside edges didn't get very numb.
Okay.
Erez, fantastic day here. Not to cut you off, we're going to obviously off camera complete the procedures for this young lady. But could you give us like a quick summary of what your thoughts are in general and your business approach overall?
Yeah, absolutely. I would say, you know, for me, I think everybody has to understand their competitive advantage. What's your angle, so to speak? And for me as a young plastic surgeon, I think technology and delivering results using technology is a key component to how we approach patients. So an InMode, frankly, has been, you know, thanks to you and Spiro, Chris, has been a big part of that. So,
You're very kind for saying that, but you're your own guy, man. Seriously.
No, thank you. But truthfully, like if we have patients that are young and just want some skin tightening non-invasively, then we utilize the Evoke, the Evolve. Once we have patients in this treatment gap group, where we're really talking about more kind of high power skin contraction, we're talking about the Embrace procedure, body tight, face tight. And I think for us, we really are able to capture that treatment gap group non-surgically and comfortably under local anesthesia, and it really gives us a big competitive advantage here. So I hope you enjoyed this. This is basically a way to show you our approach to Embrace AccuTite full face with Morpheus, as well as the axillary roll and above the knee area. And we're going to continue the treatment, but I'm happy to take any further questions.
Well, Erez, this has been fantastic. It's great seeing you here.
Likewise,
Much
thank you.
success. We'd like to mostly thank your patient today.
Thank you very much. Yes.
And Rosa Pinto, who's been wonderful here, been very patient with us. Once again, Chris Chia, Lisa Metler, Ryan Windes, and Justin Ross. We're signing off here in Dr. Dayan's wonderful Avance Plastic Surgery Institute here in Reno, Nevada. And we're going to continue going. And please refer to InMode University Educational Series for any further information from peer to peer. Thanks, Erez.
Thank you very much. Thank you guys.
Till next time.